So my case is a 76-year-old man with past medical history of ischemic cardiomyopathy. He had a BIV-ICD as well as a HeartMate 2 placed in 2016 for destination therapy. He recently started complaining of dizziness, not feeling well, was started on IV milrinone, which did not help. He had multiple low-flow alarms on his LVAD and was referred for MDT evaluation. His other past medical history include coronary artery disease and aortic insufficiency. So here you can see on his TE, he has the LVAD cannula here in the apex. It's directed towards the septum, but it does have clear laminar flow. There was no evidence on echo that there was any kind of thrombus or obstruction, and he has at least moderate aortic insufficiency. Based on this view, it looked central. It looked like it was valvular. It looked like it was central. However, on 3D, which I find to be very helpful, you can see that the leak was not central per se. It was right in the center or near the edge of the non-coronary leaflet. So he had a perforation and then in the aortic valve leaflet itself. And this was thought to be the etiology of his aortic insufficiency and why he was starting to feel his current symptoms. So at the MDT he was presented, he was thought to be not a surgical candidate. He was at least moderately frail. He needed help with all of his outside activities as well as housekeeping. So he underwent 4D CT, as you can see here, again for annular measurements, but also to evaluate for any kind of thrombus or problem with his LVAD. You can see his aortic valve leaflets are thin, they're mobile, and there's not much calcification there on the leaflets themselves or on the annulus. And then great shot there of his LVAD cannula with no thrombus or any kind of obstruction. So measurements, his aortic valve annulus by CT measured about 445 square centimeters, and the optimal deployment angle was also provided by our radiology team. So knowing that this valvular area, he was then sized for a sapien. He would have fallen in the 26 millimeter range, and then for an Evolut, he would have fallen in the 29 millimeter range for a valve. So looking at the oversizing, again, keeping in mind that there was no annular calcification here at all, he would fall about 17% for the 26 millimeter sapien and about 20% for the 29 millimeter core valve. So again, at our MDT, he really didn't have any other options in regards to surgery. We discussed the off-label use of using a TAVR valve, and in this case, we did proceed with the sapien. So here you can see that the wire crossed the aortic valve rather easily. His aortic valve did open about every fourth cardiac cycle, so they didn't have a problem there. So they brought in the sapien valve, and then using both multiple aortograms as well as TE, they deployed the valve. Unfortunately, he did have a significant paravalvular leak after this valve deployment, and we decided to do post-dilation. You can see here they're dilating. Now, according to the interventionalists, they think that the valve may have shifted a little bit after balloon dilation, but none of the fluoro images were captured of that. So what I have here, I do have the TE pictures. So you can see here the wire was across the valve very nicely, and then this is what it looked like after it was deployed. It does look like it was deployed deep on echo, and then we sweeped with color, initially just central, so we were all happy. We were about to congratulate ourselves, but then, you have to do a complete assessment, move in, move out, and check all their views, and you can see here, in fact, he did have severe paravalvular leak from the lateral aspect of the stent prosthesis. So, this was concerning for the whole team. The interventionalists did also do an aortogram because they wanted to confirm. And there you can see a huge amount of paravalvular leak. So unfortunately, the valve is deployed at this point. So we all stood there and said, well, what do we do? The heart failure specialist was there, interventionalists, anesthesiologists, we all discussed. And the patient was fairly stable, surprisingly. He did not require much more milrinone than normal. He was on his normal amount. There was no alarms on the LVAD, and we waited to make sure that the valve didn't move any further, that it was fairly stable. And at this point, we decided to just abort, do no harm, see how the patient did clinically, and bring him back if needed. So he made it about 3 weeks when he started to have hemolysis and the beginning of kidney failure. So we brought him back. And at this point, you can see, again, the paravalvular leak, very present, still severe. But the valve itself does not open with systole. So, to cross the valve at this point, we were afraid by doing the traditional antegrade method, we would dislodge the valve. So we decided not to go antegrade, but to go retrograde to reduce the risk of further valve dislodgement. So we went in, we did a transeptal puncture, which is fairly uncomplicated. And then you can see here the balloon tip catheter floating into the LV, ultimately LVOT. And with a little bit of luck and persistence, they were able to cross that aortic valve.
Oh my God.
There you go. And then snare it to externalize the wire and form a rail. So after that was done, they went ahead and used the Mullen sheath. They were able to cross the aortic valve and deploy the new valve slightly higher. At least now they knew where the annulus was based on the prior valve. And you can still see that paravalvular leak with the aortogram. So after they felt comfortable, they did deploy that valve in valve. You can see here how it looked like. But again, still paravalvular leak. So we decided to post-dilate, as you can see here, both on fluoro and then on echo. And thankfully, after this post-dilation, even with my sweep, we were not able to get much, just trivial paravalvular leak. So he did well after this. Because we created iatrogenic ASD in someone with an LVAD, we had to close that. So we went ahead and closed that on our way out. And ultimately, he did very, very well. He's about a year out now from this procedure with absolutely no alarms, and he's doing great, and kidney failure is resolved.
Great.
So thank you.
Wow.